Good morning from Madison, Wisconsin. Here is almost 9 a.m. In the morning. Good afternoon, good evening, wherever you are. Dear Vlad, dear Imad, thank you for your continuous efforts and teaching worldwide, teaching the neurosurgery worldwide. And thank you, organizing committee, moderators, and distinguished speakers. I learn a lot as always, and I have mentors, teachers, master surgeons here with me today. So I'll try to go brief and try to reflect my take on this endovascular era. You know, the golden era was the 70s, 80s, 90s, and all the masters came out and then taught us the microneurosurgery in treatment of intracranial aneurysm. Then introduction of the coils and I think I am in the institute that the first Guglielmi detachable coil was used. Then ISET came in 2015, and that's where the true endovascular era started. What is the endovascular era? Why we call it endovascular? And why did we lose this craft? Or are we really losing it? Is really microneurosurgery for brain aneurysm dying? Most people will agree, yes. And who should do the microsurgery? Should be done by the hybrid vascular neurosurgeons, vascular skull-based neurosurgeons, or so-called open vascular surgeons? Or should we call them intracranial microneurosurgeons? And are we training neurosurgeons to be microsurgically proficient? Yes, no, maybe so. And can endovascular treatment treat all aneurysms? And I'll try to reflect my perspective in these questions, and I show you the cases. We know all these. There are multiple options in microsurgical treatment of intracranial aneurysms, but you know I think we neurosurgeons, microneurosurgeons, are as guilty as the industry and the interventional colleagues, pushing away these cases because either we didn't want to deal with these very sick patients, such as poor grade subarachnoid hemorrhage and aneurysmal cases, or difficult to access. And we didn't difficult to access cases like basilar tip, paraclinoidal, intracavernous aneurysm. We didn't understand the true anatomy of these aneurysms and the surrounding structures. Although Professor Dolenc started the cavernous sinus surgery, until Ali Kurish rejuvenated this, many people were not even aware of the cavernous sinus surgery, and believe it or not, in the 21st century. So paraclinoidal aneurysm, intracavernous aneurysms, there will be cases, and there are still cases, microneurosurgery is possible. Such as this case, the patient presented with the 6th nerve palsy, and how should we treat it? Flow diverting stenting, bypass trapping, clip reconstruction, or observation. This is a young patient and female. She wants this to be fixed because of her progressive 6th nerve palsy. And of course, she goes to flow diverters, right? And I'm not the interventionist, but I can tell you easily, I don't think any flow diverter, any technology in now or next 5-10 years, they will be able to anchor the stent here. There's no way. And they couldn't. They tried multiple times, and finally they said they couldn't, and they remember there are people who still can do the microneurosurgery, and I did the bypass trapping, and immediately in a few weeks, her 6th nerve palsy completely improved, and she's been doing wonderfully fine with this radial artery interposition graft. And there are cases of paraclinoidal aneurysm and multiple aneurysms. Multiple aneurysms is a perfect setting for microneurosurgery. If there are multiple aneurysms, I don't think we should consider endovascular options. And this is a relatively young patient, this large ophthalmic aneurysm, broad base. And there's also ICA bifurcation aneurysm, and small aneurysm as very likely a perforating branch aneurysm. So this patient was offered pipeline stenting for this. But what about this one? We know that pipeline flow diverter is not going to take care of this aneurysm. And patient herself brought the issue that I have two aneurysms. I want these aneurysms to be gone at one sitting if possible. And if patient knows better than doctors, we have a problem. And then I did the surgery the way Dr. Dolench and Dr. Krish described, extradural clinidectomy, and then the wide Sylvian fissure opening for the ICA, bifurcation aneurysm, and sharp dissection. And this has been demonstrated by multiple presenters already, and minimizing the brain retraction and not continuous retraction, but the suction hand retraction, dynamic retraction, and separating these frontal and temporal lobes, and eventually getting to this ICA bifurcation aneurysm is like a perforating branch aneurysm actually. This is the choroidal. There are two branches coming from the neck of the aneurysm and one from the right on the other side of the dome. Now we established that this is the ophthalmic aneurysm, and then we're going to dissect that, get the baseline ICG green. Is it crucial to know anatomy of this distal dural ring and this region? And without that, this aneurysm is quite proximal, and we won't be able to hit this aneurysm completely. And what we learned? We learned the skull-base anatomy. We learned this anatomy thanks to our mentors. And now we can clip this aneurysm safely and completely. And we have the proximal control. We have the distal control. Dr. Ture showed the bipolar coagulation. And it's not enough dissection. I need to get a little more, and I need to clip reconstruct this with multiple clips. So you see the ophthalmic artery origin here. This is a very broad base. I need to preserve that, and I need to do like a multiple clip reconstruction of the aneurysm. And at the end, there was a dog ear here. ICG green showed that. And this here, I'm going to put a small clip there. You see ICG green showing the aneurysm. That part of the dome is filling. And I'm going to crash that with the small micro clip, get it done. So, and I also clipped the ICA bifurcation aneurysm here. We have to be a little creative with these. So we need to preserve those important perforators and get rid of the aneurysm in same sitting. And that's done, and nice angiographic and clinical result. Patient did very well. So patient brought the doctors to treatment options, and it's embarrassing, right? But this is the case, and always they will consider putting something and not treating the other or coming back. So multiple aneurysm is the perfect cases for the microsurgical treatment. This is another case, supraclinoid ICA fusiform aneurysm, giant aneurysm, is PCOM segment. Patient has a progressive left-sided vision loss, and this patient is with the mild medical morbidities. And what are the options? Of course, flow diverting stenting, right away. And we don't have much option for clip reconstruction because this is a almost 270-degree involvement of the ICA, and its clip reconstruction is not going to be possible because of the fusiform nature of the aneurysm, and then the bypass trapping. So we have two viable options. Of course, patient goes to do flow diverting stent placement, two separate sessions apart from each other, like almost 2 weeks, tried by 3 outstanding endovascular specialists, and each session took almost 14, total 28 hours. So this itself is morbidity. And now they fail. And I could have told them this is going to fail. I don't know these dynamics, all other things, but I know when you look at the angio, this is going to fail. What is the next? There are not many options. We have to bypass and trap this aneurysm. We use radial artery graft. First, we expose the neck, expose the sylvian fissure, and get the fissure ready. Important must-do things are preservation of the normal anatomy. When you are trapping, you trap at the segment and exclude the anterior choroidal artery and exclude the ophthalmic artery. So we just got the glimpse of the artery aneurysm there. We're going to move, prepare the M2 trunk. And I like to use the non-dominant M2 for bypasses. If something goes wrong, I know that I'm not going to hurt the dominant one. The bypass is done. And this is a high bifurcation. Normally, I will do external carotid. But in this case, I'm going to use the common carotid because it's bifurcation at the C1, C2 level. And I'm going to use a vascular punch, something I learned from cardiac surgeons. So vascular punch makes a sharp edges, and then I extend that and use that. And then once we are done with that, bypass is done, I'm going to do extradural clinoidectomy. Is much safer, more anatomical than the intradural clinoidectomy. Drilling the clinoid intradurally when you have the monstrous aneurysm is more dangerous to me, and we'll perform that so we can preserve the ophthalmic artery. Now we have that, and this is going to be the proximal trapping clip distal to the ophthalmic artery. And now we are taking the clips away from the internal carotid artery in the neck, and then we're going to go for the choroidal and PCOM. We have to trap the PCOM in the perforator free segment and on the ICA side. And the last trapping clip and the choroidal is preserved. PCOM perforators are preserved, and aneurysm must be gone now, right? So bypass is patent. What we're going to do, we're going to open the compress the aneurysm as I puncture it, and my residents get nervous. They say, "Oh, it's still bleeding." Nah, it's just trap blood and decompress. You don't have to remove the aneurysm. And with excellent results, good clinical and radiological outcome. ICA bifurcation giant aneurysm, another case. This is a mass effect. I wouldn't offer any endovascular options, but this patient, of course, evaluated by endovascular colleagues, and I prepare for bypass, trapping, and clip reconstruction if possible. If possible, I like to go clip reconstruct these aneurysms. If not possible, then I have options performing the high flow or low flow bypass or combination bypasses. And this is a very good results again. Basilar tip aneurysms. Dr. Krish showed beautiful cases, and this case is important. This patient himself didn't want to have an endovascular treatment, posteriorly projecting, superior, slightly posteriorly projecting basilar tip, but associated larger complex ACOM aneurysm. Another good case for microsurgical clipping. And there will be cases like this, multiple aneurysm. You can deal with the same setting and less pricey and much more efficient and effective. Of course, stent coiling is proposed and offered, but patient didn't want to have it and didn't want to come and have multiple procedures, and we preferred clipping. And again, this is like an Ostrix hardware software showing the anatomical relationship and sectioning of the dural fold, the way Dr. Krish described, and opening this dura along the sylvian fissure, and the rest is microsurgery, applying the principles of microsurgery set by our mentors, Professor Yaşargil, and the people who follow his footsteps. Sorry, I'm in the operating room, so phone is going on. And then under temporary clipping, we bipolar remodel as much as we can. And this is the pilot clipping for ACOM aneurysm. And I'm not happy with this clip because it's Dopplers, but it is not Dopplering perfectly fine. And then I did the ICG green, is little delayed flow in the contralateral A2. So I opened the aneurysm because it's quite atherosclerotic and you don't want to open too close to the neck. So I need to move my first clip So it is not, it is, seems like stenosing the contralateral A2. And also I don't have full view of these tiny vessels coming from the A1, A2 junction. So that's done and everything looks good. All the other vessels are filling. Now we can move to the basilar tip and opening the oculomotor triangle, freeing it, and cutting the PCOM after coagulating at the distal part of it close to the P1, P2 junction, and then finding the this superior posteriorly projecting basilar tip aneurysm, exposing everything. This exposure helps you to see the everything, including the proximal control, and under direct vision, clipping this and making sure you see all the P1 perforators right around the aneurysm, and then puncturing the aneurysm. And it, because it's atherosclerotic, that I'm going to crash it with the second clip. And then we'll do ICG green, and ICG green will show all the perforators, and the aneurysm is completely gone. And again, this patient was very interesting patient. He didn't want to have any angio or anything like that. So he had very good outcome. ACOM aneurysms, almost always microsurgical in my opinion. I mean, I didn't see any aneurysm we cannot clip. If we cannot clip, we can do bypass. So, and there's another thing, right? Grade 5 subarachnoid, grade 4 subarachnoid hemorrhage, poor grade subarachnoid hemorrhage. These are the black sheep of the intracranial aneurysm cases. You know, people, they don't want to deal with it. This. I have a large series of grade 4s and 5s. We have very good results, and I'm trying to publish, but I get blocked by the lovely endovascular colleagues. So this is a healthy Wisconsin farmer, and these are the treatment options for grade 5 subarachnoid hemorrhage from ruptured ACOM. Doing nothing, observation, let him improve a little bit, then treatment. What if he bleeds same time while waiting? Coiling, stent coiling, clipping decompressive craniotomy. And even people are doing this decompressive craniotomy and coiling. I don't understand why, but people do. So very angry brain, but that's okay. And we'll go apply the principles of the microsurgery, opening the lamina terminalis, exposing as much as possible, very swollen brain. But it's a good projection, and we get the ICG green baseline and go, and we'll apply the pilot clip, bipolar remodel the aneurysm, cut and decompress completely. And this is the pilot clip you see, but is pilot as introduced by Professor Yaşargil. So you other side, and look for every single vessel and be perfect. This is the only and the best time for you and the patient to get the best result. Okay, so you got to do this, and it's I'm not happy with this. I'm gonna go move, and I puncture. It's not filling. I bipolar remodel, and see I'm not happy in this corner, and I have to be perfect. This is the best chance. I don't want to come back for anything. See, and then you'll go look better way, cut the aneurysm, mobilize it, so we can see the other contralateral side. I come from left, right. I don't choose my approach. I choose my approach depends on the A1 dominance. If codominant, I'll come from the right side. And also I pay attention to the neck. The aneurysm is cut. And this patient, believe or not, 1 year, he's still farming, okay? And very good results. Pericallosal aneurysm, in my opinion, almost always microsurgical. Like this young man presented with seizures, proximal pericallosal aneurysm, you prepare for bypass, you prepare for everything, but first look for the simple clip reconstruction and decompression. That's what we did, combined transsylvian and interhemispheric, and we had a good results, and patient did very well and seizure free. And this patient is more complex, although aneurysm is smaller. Again, proximal left pericallosal aneurysm, partially thrombosed, vasogenic edema in very young patient, and it's fusiform. Pericallosal artery comes here, enters, comes out. And you see the distance between both A3s. So A3 may not be a good bypass option. I don't think there are good endovascular options on this patient, but we always evaluate it. And most important thing is you can simply trap this aneurysm if there's a good posterior pericallosal filling. Unfortunately, there is no. So we exercise all these options, A3 to A3 side bypass, A3, STA trunk to A3 bypass with radial artery or saphenous vein. He's very young, and we don't know how long radial artery he will have. So and that was an option. We prepared the arm and the leg for the potential. I first put the temporary clip. See, it's a very delayed filling. So this is simple trapping. Is we measure, and our plastic surgery colleagues expose the arm and get the radial artery. But boom, we measure 18 centimeter. They harvested 13 centimeter. So I had to move my bypass conduit from STA trunk to the frontal trunk so I can make up for the short distance. And also there were holes in the radial artery. And this is a weekend case. And then we did the A3 radial artery bypass first. And then we come up with due to the significant size mismatch, I had to do tapering technique like this and then make the radial artery smaller so I can do end-to-end anastomosis. And that's done. And we trap the aneurysm. So patient did extremely well. And we'll see radial artery graft filling the A3 completely. And this is post-op, late post-op, radial artery filling the A3. So if you cannot clip reconstruct, you can do bypass and trapping, and that's possible. In nowadays, you cannot say, I cannot do bypass, I can do skull base, I cannot do skull base. We have to be all proficient on all microsurgical techniques. Neurosurgical armamentarium should be maximum. MCA aneurysms, not always, almost always microsurgical in my opinion. Like this one, we prepare for bypass, I was able to clip reconstruct. This one, smaller, but very distal, very dysmorphic aneurysm, angular branch comes out, and other branches, you can really appreciate it, what branch comes in, what branch comes out. We did like 1 million images, and I couldn't conceptualize in my mind 3D-dimensionally which one is the best option for this patient. We prepare for radial artery, we prepare for STA, we prepare for everything. This is the artistic drawing of the true anatomy of the aneurysm. This branch comes directly from the dome of the aneurysm. There's another branch right before aneurysm, and then there's another dysmorphic fusiform aneurysm. And this branch, you cannot see distally after this point. So it's a challenging case. We'll do bypass in this case for sure for the angular branch, and then we'll see what we can do for this. Options are another bypass, but it's quite distal in the fissure. Frontal branch won't reach there. One option is inside to bypass or radial artery bypass to this branch, but this branch you cannot see. Parietal operculum obscures all these, and it's very deep in the sylvian fissure. So we prepare for STA bypass. We will do the bypass for the angular artery right at the coming out, where it comes out from the fissure, and bypass is working. And we'll trap the angular branch, and then go for the CG green. ICG green shows patent bypass, and then explore the aneurysm. So this is the branch. See, the branch is this one coming, and this is whole thing. Actually, you cannot see through aneurysm. This is also fusiform. dilatation of the origin of this aneurysm. I create a neck here. I exclude the main artery here. So, and now I have left with this one. This aneurysm is done. I need to put a clip, reconstruct, because it goes under and I cannot really see what's coming out. So inside to bypass is not option. I dissect around it, bipolar remodel, and eventually do the clip reconstruction with the angled fenestrated clip, and open the other aneurysm and taking care of. So you can do multiple things. You can do clipping, bypass, if necessary, multiple bypass. But I like to do, if possible, clip reconstruction first. To me is more natural. Again, very good outcome. Pica aneurysms, almost always microsurgical. Like this case, previously ruptured, coiled, and pica is coming very close to the neck. They leave a base there, and in 2 years, that base starts getting bigger. And this is a far lateral case, and you see coils in these cases actually at the outside, and sometimes even in the lumen of the vertebral artery. It's very stuck, and I have a very small portion of the aneurysm I can clip, and I had to restenose the origin at the vertebral artery, so then I can preserve the pica and same time clip the whole thing. And after clipping, soon we will realize you'll see the clips actually in the lumen of the vertebral artery. You see here. So, and this is clip. This should have been done before. So each procedure carries the risk, right? Patient had the endovascular coiling, and this is surgery. We are subjecting patient to do 2 procedures, risk of 2 procedures. Doesn't make sense at all. And this is a dissecting aneurysm, and very tough case, grade 5 subarachnoid hemorrhage, and all kind of difficulties we experience. Look at this, pica cannot be done because very high riding. You have to resect 2 picas, very steep posterior fossa, extensive venous plexus around the V3, and then we go to the radial artery graft, and during the exposure, radial artery got thrombosed. And we left with the cephalic vein. Luckily, we found the cephalic vein, and we did the cephalic vein V3 bypass and then trapping. It's very much, see, it's very large conduit, but it worked, and we were able to trap the dissecting segment of the pica. And again, Hunter's grade 5, but he started improving. This is a posterior fossa subarachnoid hemorrhage. They have excellent mentation. Even they have physical disabilities. After they improve, their mentation cognition is excellent. So we shouldn't give up on that.
1 minute, please.
I am finishing, Vlad.
Good.
Okay, so we are back to where we were, right? Is microsurgery for aneurysm dying? I say no. There will be always cases needing microneurosurgery, okay? They come up with all this technological advancement, improvement, but at the end, last 20 years, every year I am hearing like there's new one, there's this new stem, there's this Elvis Senior, Elvis Junior, Elvis this, pipeline, SOFI, whatever. Who should do the microsurgery? Intracranial microneurosurgeons, okay? We do glioma surgery. Yes, we do the glioma surgery in a way we remove the AVM. We do skull-based surgery. We do acoustic neuromas the way we learn from Professor Yaşargil. Are we training neurosurgeons to be microsurgically proficient? In general, no. Forget the training anymore. Everybody wants to do endovascular spine, choose the easy way. But I do, and I know master neurosurgeons in this panel, they do as well. Can endovascular treatment treat all aneurysms? No way. There's no way. I don't think my lifetime I will see this. So laboratory practice. That's the most important thing, okay? To increase our neurosurgical armamentarium, to be proficient with all these techniques. We need to spend not 1 year, like Professor said. I say minimum 2-3 years. And this is a lifetime training, okay? I still go to the lab. And this is our lab. So you need to read. You need to read these. You need to listen. You need to watch your masters. And you need to go to the lab, dissect, learn. Then you can perform much better. Again, I stop here. Thank you very much. Thank you for your time and this wonderful panel and session.
Mustafa, thank you very much. That was clear and very concise as well as Ali. What I like in these lectures is that we still are in favor of surgery, and we are seeing that surgery is much more efficient and precise than any endovascular treatment. That's also the question of hybrid neurosurgeons, like they are appearing now in US mostly. I can hardly believe that you can be a world champion in table tennis and skiing. You can be either or. And that is, in my mind, the same with these hybrid neurosurgeons. Do you agree?
100%.
Thank you. And
thank
you for the lecture. To all lecturers, please check the Q&A section on your screen, because there are questions to Ugur, for Ali, I guess. So please check these questions.
Sure, will do.